Okay, I think we're going to get started. Thank you so much for everybody coming today on July 3rd. We appreciate you. It is with great pleasure that I get to introduce Dr. James Chenoweth, who I've actually worked with since he was a baby doctor in 2011 in the ER. Dr. Chenoweth is from Medford, Oregon. He completed his undergraduate degree at Union College in Lincoln, Nebraska, and he then attended Loma Medical School and graduated in 2010. He then started an emergency residency at UC Davis from 2010 to 2013. After that, from 2013 to 2016, he completed a Toxicology and Research fellowship, including Masters in Advanced Studies and Research. And he has since held an Assistant Professor of Emergency Medicine and Toxicology position here at UC Davis, and he's board certified in emergency medicine and both toxicology. His research interests include poisoning and drug overdose, direct-acting oral anticoagulants, and novel psychoactive substances. So with that said, I will turn it over to Dr. Chenoweth. Thank you.
All right. Thank you, Jamie. She has known me ever since I was a little baby doctor, and she did a wonderful job explaining to all my patients that I really was old enough to be a doctor. I still have to explain to my patients that I am old enough to be a doctor, but this time I get to say that I'm the boss, so they take it a little easier. There we go. All right. So to start with, I have no conflicts of interest to disclose. So starting with kind of a clinical case, bread and butter toxicology case. So a 2-year-old male is brought in by ambulance. They're being found altered at home, and a partially chewed pill is found on the ground where he'd been playing. Can't really see what the pill's made, what type of pill it is. It's lost all of its scores and color and everything. And the question is, this patient comes in and is presenting to you, what do you do? The goals of this is to kind of give you an overview of what the practice of toxicology really is, with a little bit of poisoning epidemiology thrown in. And then the majority of it's going to be discussion of what are called toxidromes and kind of underlying pathophysiology of a toxidrome. And then discuss a little bit the basic treatment of poison patients. So going back to our little 2-year-old, it may not necessarily be a question of what do you do, but who are you going to call? You're not calling them, you're calling the poison center. So who remembers the Mr. Yuck stickers? Does anyone remember these? I remember being a little kid going around the house applying the Mr. Yuck stickers to everything and anything that I wasn't supposed to eat, drink, or get anywhere close to. Has the poison center number on them. They've since been replaced by other stickers, but I have a soft spot in my heart for Mr. Yuck. So the very first poison control center was started in Chicago in 1953, and it was started by a toxicologist who had become known in the area for having really good knowledge of poisonings and overdoses and exposures. And he actually developed a series of 3x5 cards that he would use whenever he got a call. It got to the point where he was getting calls at home all hours of the day and night because he was the only one that people knew to call. And he's like, well, this information seems really important to people, but I don't think I really want to be the one giving all this information all the time. And so they developed a place that everyone could call with just a single number. So anywhere in the country, you can call the poison control number, and it will link you to the nearest poison control center in your area. And once you call poison control, you're going to be talking to someone called a specialist in poisoning informatics, or a SPI. They chose this acronym because poisoning informatics specialist, the acronym PISS, wasn't really anything anyone wanted a part of. These are nurses, pharmacists, PharmDs, all under the direction of medical toxicologists who have specialty training in how to answer these calls. So they have to do extra courses in taking poisoning calls. They have to do a certain number of supervised calls every single year to maintain their certification. And then at any point in time, if you call the poison center, if it's a very strange case or a really sick patient, they'll be giving one of us a call. So a medical toxicologist, we're always on backup for every poison center in the country. And so we're always available, and sometimes advanced practitioners will want to talk to us specifically to give extra information about the poisoning, whether it's just for information purposes or if there's something that's not being understood about our recommendations. Medical toxicology is a subspecialty that focuses on poisoning, overdose, environmental exposures, bites and stings, essentially anything anyone can be exposed to. We're kind of expected to be able to at least give rudimentary advice on. So any rattlesnake bite in the area, we get a call to the poison center, and we help out with those. Drug overdoses, occupational exposures, anything along those lines. It's a 2-year fellowship post-residency. I added a year on to do research training, subspecialty board certification. And you can do it from almost any residency training program, although most of us are emergency medicine trained because most of the programs are actually through emergency medicine departments. So each year, poison centers take about 3.1 million calls. And of those, 2.2 million are actual toxic exposures. The rest of them are information calls. So around Christmas, there's a lot of calls about, if my kid eats the poinsettia, is that something I need to worry about? The answer is no. Poinsettias aren't anything to worry about. But we get a lot of those calls. Or I found a pill on the ground. What is it? Things along those lines. California poison control centers take about 10% of those calls. So we're one of the busiest poison control centers in the country, and for that reason, we're broken up into 4 different divisions. So there's, and those have various geographic locations throughout the state. So Sacramento has one over at the Staff Support Services building. There's one in San Francisco. There's one in Fresno that covers kind of Fresno, LA area, and then there's one down in San Diego. So we take 900 calls a day. And then here at UC Davis, we have our own toxicology consult service. So if someone calls us, we'll come in and do an in-person evaluation, give recommendations. Kind of nice to get some bedside evaluation of a patient because you can learn so much more by actually looking at a patient as opposed to hearing someone else describe what they're seeing to you over the phone. And we do about 500 of those consults every year, and that number is going up every year. The breakdown of who gets poisoned, it kind of makes sense. Kids less than 5 are about half of the calls that we get to the poison center. I do not have any children myself, but anyone who has children would know that around those ages, they're sampling their environment, and everything that they come in contact with goes into the mouth to various degrees. And so we get a lot of phone calls about accidental exposures. The next biggest group is adults 20 to 59, and this is where you're entering into a large region of overdoses, polypharmacy, drug abuse, things along those lines. And so we get a lot of calls as it relates to that. So in general, once we get a phone call, if we're giving recommendations through the poison center, not actually seeing them in person, we give general treatment recommendations. And at the very top of the list is going to be what we call supportive care. Now, supportive care may kind of sound like a cop-out, but it's a wide variety of different things that we want people to do. All starts with the airway, breathing, circulation that every evaluation would have. In most cases, we kind of encourage people to prevent hyperthermia because in a lot of exposures like stimulant abuse along those lines, the mortality actually increases as the temperature increases. So we make sure that people are actually maintaining normal thermia. We give recommendations on things they can do to maintain organ function. Primarily, we're focused on the liver and the kidneys because that's how we're going to get rid of whatever they've been exposed to. And so maybe IV fluids, something along those lines, maybe even vasopressors. We give a lot of recommendations for benzodiazepines. Those are our favorite medications to recommend. And it's because they're nice, clean sedatives. So we know exactly how they work. We know what the dose-response effect is. And so we're very comfortable with their use. We may give recommendations to give vasopressors. Primarily, we'd be talking about things like norepinephrine is our preferred because it's a direct-acting vasopressor. In certain situations, we may give recommendations on things that can increase excretion. So dialysis, there are certain medications like lithium and aspirin that are very amenable to dialysis in certain situations. And then chelators, we give some recommendations, not as common as we used to, but things like Suxamer for lead poisoning. Along those lines. And then every once in a while, we give a recommendation for a specific antidote. I would say majority of cases, there isn't a specific antidote for the exposure that we're being consulted on. But the number one thing that we do use is naloxone for opioid toxicity. That'd be shortly followed by N-acetylcysteine or NAC, which is used for acetaminophen overdose. And then the rest of these atropine, Pralidoxime, Fomepizole, Flumazenil, Physostigmine, methylene blue antivenoms, those are going to be much less commonly recommended. So when we get called into the room, this is kind of what we feel like. We're entering into an unknown situation, and we're trying to piece together different clues that can help us figure it out. Number one, of course, is going to be the history. If the patient will tell me what they took, that makes my job a lot easier, because then I can give some very specific recommendations. But often these patients either won't tell you, they'll lie, or they'll be too obtunded to be able to actually give you accurate information. And so we're left trying to figure out, of the possible exposures, what do I think they actually took? And the main thing that we use for this are what we call toxidromes. So toxidromes, made-up word for toxic syndromes. These are constellations of symptoms that are due to activity on one of these three things: a single receptor, a single neurotransmitter, or a single neurotransmitter system. So you have to meet one of those criteria in order to be actually considered a true toxidrome. These are useful for helping to identify what we think a patient was exposed to. There are 5 primary toxidromes: Impassible Medic, Muscarinic, opioid, sedative hypnotic, and cholinergic. Muscarinic toxidrome is also called cholinergic at times, but to be, for semantics' sake, we're calling it Muscarinic. There are many minor toxidromes that exist. They're not included in this because they don't meet one of those 3 criteria. So, for example, there's a toxidrome that we talk about on our toxicology rotation, where we're talking about the hypotensive bradycardic patient. And that's a constellation of symptoms that can come from a wide variety of exposures and a wide variety of neurotransmitter systems. So you could have a calcium channel blocker overdose. You could have a beta blocker overdose. It could be something like digoxin. All of those different things will cause that unique constellation of symptoms, but because it's not a single neurotransmitter system, a single neurotransmitter, we don't consider it a true toxidrome. So you can kind of figure out what someone was exposed to in most situations just using one of these 5 toxidromes. The very first one, Impassible Medic, this is caused by all sorts of things, things like cocaine, methamphetamine, bath salts. If you've ever heard of bath salts, they're all over the news. These are what are called synthetic cathinones, which are derived from a substance called cathinone that's in a plant called cat, that's used in North Africa and South and Yemen area as a stimulant, much in the same way as in South America people chew coca leaves. It's not really transported anywhere else in that form because it degrades over time. So you can't just send the plant over and people chew it to get the stimulant effect. So instead they created these synthetic versions that were technically legal at the time and were sold as legal highs, as legal stimulants. So all of these different substances act to increase excitatory neurotransmitter release, specifically focused on the sympathetic nervous system, which is why they're called Impassible Medics. I use this diagram because it was the best one I could find, even though it uses dopamine. It works the exact same way. So when we're talking about amphetamines and cocaine, amphetamines act primarily by increasing release of excitatory neurotransmitters. They also have a little bit of reuptake inhibition. Cocaine is a really potent reuptake inhibitor and doesn't really increase release very much. And these all cause kind of the same symptoms. So the very first thing you're going to notice when you're taking care of one of these patients is that they're tachycardic, and often very, very tachycardic. And because of the direct stimulant effects, this could be a sinus tachycardia, this could be rapid atrial fibrillation, this could even be something like ventricular tachycardia if a patient's at risk, like they have underlying cardiovascular disease or structural heart disease. And along with that tachycardia, they're going to be really hypertensive. This is a degree of hypertension, particularly when you see overdoses of cocaine where people can have spontaneous strokes, spontaneous intracerebral hemorrhage, digital ischemia, myocardial ischemia as a result. They'll have normal or fast respiratory rate, and it's primarily from the agitation that they get this elevated respiratory rate. Most Impassible Medics don't directly stimulate the respiratory centers like some other medications do. These people are hyperthermic. This is the #1 vital sign that I'm looking at when I enter the room for someone that I think is overdosed on a Impassible Medic, and that's because mortality directly correlates with temperature when we're talking about overdoses of these substances. So I want to know an accurate temperature in all of these cases. And they're hyperthermic primarily because of increased muscle activity, increased use of energy. They're wet. These patients are diaphoretic, often to the point where you're trying to put EKG leads on and they're just falling off. You're trying to hook them to the monitor and nothing will stick because they're just pouring sweat. They get big dilated pupils. There's a couple of different ways that you can get big dilated pupils. So the control of the pupil is through two different systems. There's a pupillary constrictor muscle that uses acetylcholine acting on muscarinic receptors, and then there's pupillary dilator muscles, which are primarily norepinephrine mediated. And so this is active dilation of these pupils. So they get big dilated pupils. Decreased bowel sounds. Remember, the sympathetic nervous system is your fight or flight. So you don't want to be using a whole bunch of energy in your bowels to digest when you're in the fight or flight response. And finally, these people are angry. These people are really angry. If you've ever seen someone overdosed on meth coming into the recess bay, all of our trauma friends have seen this before, or anyone who's spent a significant amount of time in the ED. You've seen this angry person. Sometimes they have a spit mask on, and they're locking eyes on you, and they're angry at you. They are focused. It's very directed anger. So the treatment is primarily going to be supportive care. Once again, so your airway, breathing, circulation. You make sure that they're not being restrained to the point where you're worried about their respiratory drive. You want to give them IV fluids. You give external cooling methods, of course. And then benzodiazepines. This is going to be the #1 treatment for a true sympathomimetic overdose. And how these are going to work is they're going to counterbalance that excitatory neurotransmitter release because your GABA system is your primary inhibitory neurotransmitter in the brain, and benzodiazepines activate that system. So you're trying to return the brain to a balance. And this may require really high doses. So I've seen doses as high as 16 milligrams IV lorazepam, one-time push required to actually calm this person down to the point where you can actually do external cooling measures. You can actually treat them reasonably. There's not any specific antidotes for these patients, so we consider essentially benzodiazepines to be the antidote effectively for sympathomimetic toxicity. And as I progress, I'm going to fill in this table. You'll notice there's only 4 toxidromes on this table, and I'm going to talk about 5, and that's because the 5th one doesn't really fit with the rest in the same way, so it doesn't really fit into this table, but I'm going to fill this in as we go. Next, we have the antimuscarinic or anticholinergic toxidrome. There's a bunch of different plants that can cause this. Up there on the left is Atropa belladonna. Belladonna alkaloids, that's where we get atropine, that's where we get scopolamine. Top right, that's brugmansia or angel's trumpets, also contain atropine and scopolamine. And then probably the #1 antimuscarinic overdose that we see is going to be diphenhydramine. So diphenhydramine is a very potent antimuscarinic agent, and we see a lot of overdoses of those. So this is your parasympathetic nervous system right here. So you have your muscarinic receptors that are being blocked both here and here. So you're going to get blockade of the parasympathetic response. So you're going to see kind of the opposite of the parasympathetics. And then you're also blocking the activity on sweat glands. And so you're going to get dryness from that. So once again, these patients are tachycardic. You're blocking the parasympathetic slowing down of the heart, and so you're going to get tachycardia as a result of that. However, as opposed to the sympathomimetics, they don't really see a significant elevation in their blood pressure. Their blood pressure will probably be somewhere close to their baseline, so they may be hypertensive if they have underlying hypertension, but the antimuscarinic itself isn't going to be causing that. You're going to have a normal respiratory rate. Once again, they're going to be hyperthermic, and this is a result of them being dry. So this isn't an increased energy use. This is because you're blocking the ability to sweat. They're really dry, and they can no longer control their temperature like they would normally by sweating. They get big dilated pupils, and this is because they can't constrict. So you're blocking the muscarinic pupillary constrictor muscle, and so they get dilated because they can no longer constrict their pupil. You get decreased bowel sounds, and they're agitated. Now, this isn't the anger of the sympathomimetic. This agitated patient, if you're trying to put an IV in, they may swing at you, but it's not really because they're focused on you. It's because you're messing with them. So it's a different degree of agitation that you're seeing as opposed to the sympathomimetic angry patient. Treatment for these patients is, once again, supportive care. ABCs, IV fluids, external cooling, because once again, we're trying to avoid hyperthermia because we know that hyperthermia is bad. Benzodiazepines to treat the agitation as needed, but as opposed to the sympathomimetics, there is actually an antidote that can be used for antimuscarinic toxicity, and that's called physostigmine. So it's an acetylcholinesterase inhibitor. So you're blocking muscarinic acetylcholine receptors, and by blocking acetylcholinesterase, you're increasing the amount of acetylcholine in the synaptic cleft, and you can overcome that blockade to a degree. We don't use this all that often because most situations we don't really worry about the antimuscarinic toxicity. Usually we can just support them through. We became very scared of using physostigmine in the 80s when we would see a bunch of tricyclic antidepressant overdoses. And in certain situations, you can have asystole if you give physostigmine to patients that overdose on tricyclic antidepressants. So naturally, we got very scared of using it, but it's become more popular more recently because we no longer see the same degree of tricyclic antidepressants, and in most other situations, it actually is really safe and can be a very useful diagnostic tool because these patients are confused, they're agitated, and you give a dose of physostigmine, and they are normal. It is one of the more impressive things. It's kind of like the same when you have someone that comes in with a heroin overdose and you give naloxone and they go from being dead to being alive. It's kind of unbelievable how well it works. It's quite impressive. So back to our table. Sympathomimetic and antimuscarinic look awfully similar. And so we're counting on this wet or dry. But what's the best method for determining whether a patient's actually wet or whether they're dry? And that is what's called the Tox Handshake. So preferably a gloved hand in the axilla, because everyone sweats in their axilla, right? Everyone at baseline has at least a little bit of sweat in their axilla. And so if they're dry, then that really points me in the direction of a antimuscarinic as opposed to a sympathomimetic. And it is bone dry. You'd think that, I'm putting a glove on, I'm not really going to be able to tell, but when you feel one of these, it's actually quite impressive how dry the axilla is. All right, moving on to opioid. Opioid, really hot in the news right now with opioid epidemic going on. Just a couple of definition things. Opioid is all things that act on opioid receptors. An opiate is something that's derived from the poppy plant. So there's really only three true opiates. That's codeine, morphine, and something called thebaine. We sometimes will count heroin as an opiate, even though it's a synthetic derivative of morphine. It's diacetylmorphine. And the reason why it's important to differentiate is that when you're talking about your urine drug screen that people use for trying to detect these agents, the urine drug screen checks for opiates. And so it's going to be incredibly reliable for things like morphine, codeine, and heroin. If you start getting into the synthetic derivatives of morphine, things like hydrocodone, oxycodone, it may or may not be detected. And then when you get into the full synthetic opioids like fentanyl, you're never going to detect that on a routine drug screen. So you have to have specific testing in order to actually determine whether they were exposed to that. This is a big issue currently because a lot of people's heroin is being replaced with fentanyl. And so you could have someone who has really pure opioid toxicity and reverses, but urine drug screens can stone cold normal. And that's probably because they ingested or were exposed to a synthetic opioid as opposed to a true opiate. So opioids are kind of interesting. We don't completely really understand how they work. We think that they inhibit pain receptors in the spinal cord and probably in the brainstem. And then there's some inhibition that's happening in the cortex as well. It's a very complex thing. Opioid system really highlights the fact that our classic physiology where we learn, hey, here's one nerve coming into one synaptic cleft and then it's moving on to the rest of the body. It's really much more complicated with that, with multiple systems interacting even at the same synaptic cleft. And the opioid system kind of acts as an overriding effect on all of those. So these patients have a relative bradycardia, and it's relative in relation to their blood pressure. So often, if you've seen an opioid overdose, they may have a little bit of soft blood pressures, maybe in the 90s, maybe even all the way down to the 80s systolics. But despite that, their heart rate's still going to be in the 50s, 60s, 70s. Now, this isn't the profound bradycardia that you'd see if someone overdosed on metoprolol or something like that, where heart rate's in the 20s and they're becoming hemodynamically unstable as a result of it. But they do have a relative bradycardia in relation to the blood pressure. they get profound respiratory depression, and this is what tends to kill people with an opioid overdose. They can even get all the way to the point of respiratory arrest just from a single agent opioid overdose, which kind of differentiates it from a lot of different other drugs that people will overdose on, where it's more of a combined effect or like an airway obstruction issue as opposed to true respiratory arrest. They become lizards. I don't know if you've seen that. No, I put this in because it's the best picture I could come up with for becoming poikilothermic or cold-blooded, essentially. So opioids inhibit your shivering response. So if you overdose on something like heroin, or a patient overdoses on something like heroin and they're in a cold environment, their body is going to become cold because they can't shiver in response to getting cold. And they get cold and clammy skin. Pinpoint pupils. This is the true pinpoint pupil. If you've seen it, it's very profound. You're always surprised by how small a pupil can really get when you get a really significant opioid overdose. And how this happens, no idea. No idea. About once a year, I try to look this up to see if someone's figured out exactly why people get pinpoint pupils with opioids. Still haven't found anything that actually explains it. They get decreased bowel sounds, kind of the big side effect of opioids that everyone's very aware of and can be quite distressing to patients. And they get real sleepy, even to the point of being unresponsive. So this is going to be the one situation where the treatment does not start with supportive care. The treatment starts with naloxone. So naloxone is a mu-opioid antagonist that completely reverses the effects of opioids. The starting dose should be somewhere around 0.04 to 0.4 milligrams. This may seem a little low to people, particularly if you've seen people coming in via EMS where they get 2, 4, 8 in the nose. But this is because in most situations when I'm giving naloxone, I'm giving it because I'm worried about their respiratory drive. I don't need them to be awake. I just need them to breathe. And if you've ever treated someone who's been completely reversed with naloxone, you know you don't need them to be awake. You don't need them to be awake. And so the one exception that I give to this is if someone comes in and I'm so worried about their respiratory drive, they may be hypoxic or they may not be protecting their airway, that if I don't wake them up, I'm going to intubate. And so I will give higher doses. I will start with 2, maybe even give 4 to try to wake a patient up so that I don't have to perform orotracheal intubation, because we all know that that can lead to other downstream adverse effects. Beyond that, you do your ABCs. In some situations, particularly when we're talking about our synthetic derivatives of fentanyl, you have to give a lot of naloxone, like 10 milligrams or more, to actually reverse the effects. And I don't tend to wait that long before I control the airway in those situations, because I know if I can control the breathing and the respiration, then eventually the opioid will go away and we'll be able to extubate and take care of it. And then IV fluids are often needed in these cases. All right, filling it in a little bit more. Next is the sedative hypnotic. So this includes things like benzodiazepines, your sleeping agents like zolpidem or Ambien, your barbiturates, and then all your alcohols fall in the sedative hypnotic realm. And these will all act through GABA. So if you remember before, I was talking about benzodiazepines and GABA being the primary inhibitory neurotransmitter in the brain. Well, all of these augment the amount of GABA transmission that's happening. So they cause suppression of everything in the brain. And this leads to, once again, a little bit of relative bradycardia in relation to the blood pressure. So they may have a little bit of soft blood pressures. Don't see the lower blood pressures as much with these sedative hypnotics as I've seen with the big opioid overdoses, but it definitely happens. Anyone who's been taking care of a patient and given a slug of midazolam has seen a little bit of a drop in the blood pressure as a result of that. You get respiratory depression, but once again, it's not to the same degree as you see with the opioid. Now, if you combine different sedative hypnotics, then you can definitely get an additive effect. So if someone were to overdose on a benzodiazepine and then they drank alcohol with that, then that could definitely lead to enough respiratory depression that you could have significant issues. But in a single agent sedative hypnotic overdose, this doesn't tend to be a significant problem. Once again, they get cold-blooded essentially. And that's once again because they're inhibiting the shivering. So we don't see that as much here in Sacramento because it doesn't get that cold, but anyone who's ever practiced in the Northeast knows that around the first snowstorm of the winter, there's a lot of alcoholics that live on the streets that end up coming in hypothermic, and that's because they can no longer control their temperature in the same way. Once again, cold, clammy skin, small pupils, not pinpoint, but definitely small pupils that may be sluggish to react. Decreased bowel sounds, once again, and once again, sleepy. So, you see very, very similar to your opioid toxicity. So your treatment for these patients, supportive care is going to be your primary method. So you're going to do your ABCs, some IV fluids. For your chronic alcoholics, you don't want to forget your thiamine, B6, and dextrose because these patients tend to have significant deficiencies because they don't have a normal diet. Flumazenil can be used. So flumazenil is another interesting antidote that we all became very afraid of during the TCA world time and has since come back into favor. So it's a benzodiazepine antagonist. The one issue that it has is that it can precipitate withdrawal. So if someone's chronically on benzodiazepines, then if you give them flumazenil, you will precipitate benzodiazepine withdrawal, which can be life-threatening. It can even lead to seizures. And first-line treatment for seizures is benzodiazepines, and you've effectively prevented yourself from treating the seizure that you just caused. So not ideal. In most situations, I'm going to be using this for a little kid that gets into mom or dad's benzodiazepine. That kid I know is perfectly safe to give a little bit of flumazenil to and try to wake them up so we don't have to worry about their breathing or anything like that, controlling their airway. The other situation that flumazenil is given is when we're the cause of the problem. So if I give too much benzodiazepine, or you're doing a procedure and you've completed the procedure, they're not chronically on benzodiazepines, and now you want them to wake back up. So it's used in the GI suite sometimes to reverse the effects of sedation that's used for colonoscopies and things like that. But from the emergency department side, I usually don't have enough of a history to be able to say that someone's not chronically on benzodiazepines, so I generally will avoid flumazenil. So we finished this table, but just like we saw with Impassible Medic and anticholinergic toxicity, opioids and sedative hypnotics are very similar, even to the point where I can't really differentiate the two at bedside. Like, I don't have a physical exam test. So can anyone guess what you'd use to differentiate these two? Narcan, Naloxone, absolutely. So if they wake up after you gave Naloxone, or their respiratory rate improves, or their pupils are no longer tiny, then, oh, there's an opioid. If they don't wake up, that pushes me in the direction of maybe a sedative hypnotic as the underlying cause. And then the last toxidrome that I'm going to talk about is the cholinergic toxidrome. Now, this is primarily caused by things called acetylcholinesterase inhibitors. Acetylcholinesterase breaks down acetylcholine in the synaptic cleft. If you inhibit that, you increase the amount of acetylcholine and cause all the issues. These include things like pesticides, organophosphates, and carbamates are the two different classes that we think of. Medications, they're actually carbamate medications. So physostigmine is a carbamate acetylcholinesterase inhibitor. Pralidoxime, things used for myasthenia gravis, all those are going to be carbamates. And then nerve agents. So if you see something on the news where someone was poisoned with a nerve agent, like happened to the uncle, I believe, of Kim Jong-un, who was poisoned with VX nerve gas, and that's an acetylcholinesterase inhibitor. Sarin, somantabin, also acetylcholinesterase inhibitor nerve agents. This up there on the left, that's the calabar bean, contains physostigmine. That's where physostigmine comes from. Down at the bottom, you see someone applying pesticides without proper PPE, so they're going to be coming to the emergency department sometime soon. And then the top right is actually a cutout of a bomb that contains little bomblets that contained sarin that used to be part of the U.S. arsenal, but has since thankfully been removed. So cholinergic involves all these systems. So the entire sympathetic, parasympathetic, and somatic motor systems are all part of the cholinergic system. And acetylcholinesterase, like I said before, breaks down acetylcholine into acetyl-CoA and the choline molecule. And then after it does that, it actually regenerates. And so the same acetylcholinesterase molecule can break down multiple molecules of acetylcholine. But when you inhibit that, either with a carbamate where it's a reversible inhibitor, you're kind of delaying that regeneration. So the carbamate binds to it just like acetylcholine would and kind of sticks on the molecule for a little while, preventing it from breaking down the normal acetylcholine that's being released. But then eventually, in those reversible cases, it falls off, and that acetylcholinesterase molecule can then go about its business. If we're talking about irreversible things like organophosphates and nerve agents, these bind permanently to that acetylcholinesterase molecule, and that acetylcholinesterase can then never be used again. And so your body has to regenerate more acetylcholinesterase, which kind of explains why these agents are so potent, is that you bind up all the acetylcholinesterase and you have uninhibited acetylcholine transmission. The symptoms that we see from this can be broken into the muscarinic and nicotinic systems. So we use different mnemonics for the different ones. We use, in the toxicology world, we use dumbbells for the muscarinic symptoms. In med school, I learned about sludge, and a lot of other people have learned about sludge. That I like to think of sludge as the side effects, the cholinergic side effects of medications, where dumbbells is true toxicity, and it's because it involves these three things called the killer bees. So the muscarinic symptoms include defecation and diaphoresis, urination, meiosis, bradycardia, bronchuria, bronchospasms, bradypnea, emesis, lacrimation, and salivation. And these three right here in the middle are what kill people. So the big one being bronchuria. Bronchuria is going to be the most common cause of death with these poisonings. And it's because your lungs are producing so many secretions that you're no longer able to take air in, and you're no longer able to get oxygenated. It's potent to the point where if there's a hole, there's fluid coming out of it. So it's not subtle. So if you're ever worried about missing a cholinergic toxicity, trust me, you won't. It is not a subtle presentation. The nicotinic symptoms, we use the days of the week. So M stands for mydriasis, then we get tachycardia, weakness, tachypnea, fasciculations, and seizures. You may notice that some of these are kind of counteracting each other. So there's meiosis on one side, mydriasis on the other. It tends to be the fact that in bad cholinergic toxicity, muscarinic symptoms predominate. I'm going to talk about why in just a second. But so you don't see the mydriasis, you don't see the tachycardia, you don't see the tachypnea. So if you're looking for nicotinic symptoms in one of these patients, you're going to be looking for weakness, fasciculations, and seizures. Now, why would that be the case? So back to our diagram. You'll notice that when we're talking about parasympathetic nervous system, acetylcholine, the nicotinic receptors are in the preganglionic area, muscarinic's at the end organ. This is also true with sympathetic nervous system. So you have the preganglionic nicotinic, and then the end neurotransmitter is norepinephrine. At the sweat glands, you're back to the parasympathetic, where you have nicotinic and muscarinic. We're talking about the adrenal medulla releasing epi, it's nicotinic, and then at the skeletal muscle, it's nicotinic. So if you have a preganglionic neuron going against an end organ receptor, the end organ receptor is always going to win. So if you're having excess activity at an end organ receptor, that's going to predominate over what you would otherwise see if you were just stimulating the preganglionic neuron. Does that make sense? All right. And then at the skeletal muscle, you only have the nicotinic. And there's other medications that we actually use pharmaceutically that are nicotinic agonists that kind of help explain why you see the fasciculations and weakness. So if anyone's ever seen succinylcholine being given, where you give succinylcholine, starts with fasciculations, and you stimulate to the point of weakness, meaning paralysis. So this acts the same way, just not to the same degree. So you get fasciculations first, and then later on, as you've overstimulated that neuromuscular junction, you'll eventually get to weakness. Treatment of these patients is going to be primarily supportive care, so your airway, breathing, circulation, and then atropine. Atropine is going to be the #1 medication that you're going to want to get access to if you have one of these patients come in, and you're going to have to call pharmacy because there is not enough atropine in the in the emergency department to treat one of these patients if they have serious toxicity, because the doses of atropine that I'm talking about are starting at 2, and then giving 4, then giving 8, then giving 16, then giving 32 milligrams IV push. And people that deal with this regularly will give IV pushes of 50 or more milligrams of atropine in order to actually reverse the muscarinic effects. These are really scary, really impressive presentations that require large amounts of these medications. You may require repeat dosing, and you're giving it until you actually can listen to their lungs and say, all right, I got good breath sounds. I no longer hear a lot of rhonchi. You've dried up the respiratory secretions. There's also a medication called Pralidoxime, or 2-PAM. This medication is used to prevent that covalent binding process of the organophosphates. And what it essentially is, it's essentially a carbamate that likes to bind to acetylcholinesterase, but it binds with a higher affinity than organophosphate molecules. And so it binds to the acetylcholinesterase, kicks off the organophosphate, and then unbinds later on. And so instead of taking away that acetylcholinesterase molecule permanently, you've only taken it away for a little while, with the idea that your body won't have to regenerate quite as much of the acetylcholinesterase as it would otherwise. It's only useful for the nicotinic effects. And like I said, it's used for organophosphates and nerve agents. So I went a little faster than in my practicing. I tend to talk a little fast when I'm in front of people. But in summary, toxicology focuses on poisonings and drug overdoses. Poisoning is really common, and half of exposures happen in young children. Toxidromes are going to be the primary tool that you'll use to try to make a differentiation of what someone was exposed to. And our treatment has an emphasis on supportive care. We try to augment excretion of medications whenever possible. And then in very rare, in less common situations, we'll use antidotes. Some sources. Then any questions, always remember the Poison Center. If anyone has questions they want to email to me, feel free. And that's it. Yeah. Yeah. Oh yeah, absolutely. So those are really interesting. So the synthetic cannabinoids, known as K2 spice, all those also sold as legal highs. They were developed in the late 80s and early 90s because people realized that cannabinoids actually have some potent analgesic effects. And so they were trying to get molecules that acted on the cannabinoid system that didn't cause people to get high, but did relieve pain. And so a whole series of these molecules were developed that were really potent cannabinoid agonists. The problem with that is that THC, which is the primary component of marijuana, is a partial agonist. So it provides kind of the ceiling effect at the cannabinoid system where the higher the dose gets, the less effect it has. These new molecules, the higher the dose it gets, the more effect that it has. So you just keep hammering away at the cannabinoid system. And that's why we see things like seizures, things like severe hypertension. They almost look like a Impassible Medic, but they're acting through a different neurotransmitter system. And every time we make a new one illegal, there's another one waiting in the wings that they just throw on a couple side chains and make it look a little different. It still acts on the cannabinoid system. But the problem is every time you change the molecule, you increase the various degrees of toxicity that you might see. And so we do see a fair amount of that, although in California it's not going to be as common as other places where marijuana is still illegal. Uh-huh.
I had patients that had cobalt toxicity from a metal on metal hip
Mm-hmm. Yep.
And is that just treated like lead or cobalt? When do you decide to chelate and
So chelation and heavy metal toxicity is a really interesting topic because with the exception of acute toxicity, there's really never been a study to my knowledge that showed improved outcomes with chelation. With acute overdoses of certain things like mercury, acute lead overdoses, there's definitely some benefit from chelation. But when we're talking about chronic exposures like to cobalt, like A, we don't even know if the chelators work for a heavy metal like that, and B, what we do know is that removal of the exposure is the number one thing that helps change the outcome. And for cobalt hips specifically, if you're getting significant toxicity from it, then you end up having to remove the hip, because that's the only way to actually decrease the toxicity. And for those who don't know, cobalt can cause anything up to, it can cause thyroid issues, and then it can also cause a cardiomyopathy. We kind of learned that cobalt was used as a foam stabilizer in beer, and there was a whole series of overdoses because people drank a lot of beer and then got cardiomyopathies because of the cobalt. But in general, for chronic exposures, chelation doesn't really do anything. We do it because it's something to do, but it doesn't really do anything. Anything else? All right, thank you.
My name is Leah. I'm the MCQ student. I do have a quick question about the case in the ER. So there's a 25-year-old female medical student. Do we know why? Because she is
Oh, do I hit stop recording? Stop.